Welcome to EHJ Today. At the Davos Cardiology Update, we are here together. My name is Jeroen. I come from Leiden University, Department of Cardiology in the Netherlands, and at the moment I'm fulfilling my role as President of the European Society of Cardiology. It is my honor and great pleasure to have with me Dr. Wijns, who has moved recently. You were always in Belgium, but I know that recently you have moved. Where are you now, actually?
Yes, Jeroen. Relocated recently, since a couple of months, to NUIG, National University Ireland in Galway, to take a position that is consistent with my interest in developing new devices for intervention. So it's a pleasure to be interviewed by you.
Oh, thank you. And during this meeting today, you were involved in a session on advances in interventional cardiology, your field, with a special focus on complex situations. There were three issues that were driving the total session. What were the three main topics that were discussed today?
Yes, exactly. So this session was about complex intervention. We had one discussion of advances in the treatment of chronic coronary total occlusions, reopening those vessels, even after them being closed for many years. Then we had one section on treatment of bifurcation lesions, and particularly the left main and left main bifurcation, the topic that I covered. And then we attended a very interesting debate between the surgeon, Dr. Maizano, and an interventionalist, Dr. Windecker, who discussed the interaction between surgery and intervention with these new data and new advances in technique at hand.
Which is always a complex situation, the interaction between surgery and cardiology.
It is in some way, although I think the concept of the heart team has changed in many ways how we interact with each other. If you place the patient centrally, I think the discussion becomes easier.
That's right. So, left main disease. There has been a lot of new information recently, specifically two larger trials that were published just recently. You want to allude a little bit on these trials, how this might affect the new practice?
Yeah, these were two randomized trials. Slightly different design, also slightly different outcome, because they were looking at different endpoints, but by and large, I think it's fair to state that interventional treatment of left main has made significant progress. Although if you're randomized to surgery, you may benefit from a slight benefit in the need for reduced intervention over time. Say, after PCI, you may need a new intervention in 15% of cases over time, 3 to 5 years. By and large, if you look at the hard events, death, mortality, stroke, we're facing a situation where there is equipoise in terms of results of the two procedures, which means that in selecting the best treatment for a given patient, it's no longer the technique that's driving the decision, but a more holistic approach to solving the problem of that specific patient.
So you say that it is moving a little bit away from technology rather than going in the direction of patient-oriented approaches?
Correct. I think that the patient-oriented approach is now possible more than before because the technique has been solved. Take, for instance, the treatment of bifurcations in general, and distal left main bifurcation in particular. We've evolved from trying to use complex solutions to very simple ones. And this has resulted in the fact that the technique, the procedural strategy is now standardized, better than before. Therefore, it is teachable. And also the outcomes become more predictable.
You mentioned briefly about the patient-centered approach, the holistic approach. How does this new data affect you in your daily practice? Did it change your management? You already mentioned a little bit the heart team, which is a concept that has been pushed forward recently in a lot of situations. We know it quite well from heart valve disease, structural heart disease, but also coronary disease. there is more and more emphasis on these sort of approaches. How did it affect your practice?
Yeah, I think the discussion in the heart team becomes easier when with either technique you can offer predictable outcomes. So left main bifurcation, interventionalists have to know basically two techniques. They have to master two techniques. One that is called provisional stenting, whereby you stent the main branch and you still have the opportunity to place a stent in the side branch if needed, based on very specific criteria. This is called provisional technique, plus or minus tap, T-stenting with protrusion. It's a bit technical, but that is one strategy, well standardized, that every interventionalist should learn, should master. And then there is another one whereby you may decide in 20% of the cases to go with a two-stent approach up front. And there is 2 or 3 now that are available, standardized, teachable. So you don't have to learn about 40 different techniques with different approaches depending on the operator. It's standardized, and therefore we know what we can offer. We can bring to the table when we have the discussion in the heart team about this particular patient, and then we can also consider, other aspects, patient preference, that is very important, the possibility to go for longer term with dual antiplatelet therapy, associated comorbidities that would either militate in favor of surgery or intervention. So not being focused on the technique, which is today possible, I think improves the quality of the discussion, and I believe also the outcome, whatever solution will eventually be offered to a given patient.
Just a short sidestep. The heart team is an important component. Should that be the majority of the patients being discussed in the heart team, or you feel that we should keep this for the more complex cases as your session today was about?
Yeah, I would suspect that in many institutions, the proportion of cases that need to be discussed are the complex ones. And more we do see that this complexity is no longer driven by the technicality of either the bypass or the PCI. It's driven about the complexity of the patient himself or herself, prior interventions, comorbidity, diabetes, severe kidney disease, concomitant disease, CAD and valve disease, carotid stenosis. So these are the more complex patients where, in fact, bringing more specialists, and not just the interventionalist and the surgeon, to the discussion is likely to end up with a proposal to the patient that will have the best possible outcome.
This year is an important year for interventional cardiology. You, as first president of EAPCI, the Association of ESC focusing specifically on interventional cardiology, do you want to say a few words why this is an important year for interventional cardiology?
Well, it's an important year because it's the 40th anniversary of the first balloon angioplasty. This has been a fantastic journey, I think. The concept of using the endovascular route to reach whichever target organ, starting with the coronaries but now expanding and even beyond the cardiovascular system, has been a fantastic one. Offering patient-friendly therapies based on devices has also been a wonderful journey. I had the privilege to witness this from the beginning. I'm delighted that the president of the ESC is actually interviewing me on an interventional topic. And importantly, with EAPCI and PCR, we'll be delighted to contribute as much as we can to the ESC Congress, because you have decided with the program committee that the anniversary of balloon angioplasty would be the main theme of the ESC Congress this year. Thank you for that.
Which is important. And it is important for basically every clinical cardiologist. It made a huge difference in clinical cardiology, and that is why we decided to take this as a theme for the next ESC's Congress in Barcelona. William, I thank you very much for this pleasant interview. It was my pleasure to discuss with you, and I welcome everybody to the ESC Congress in Barcelona, where we will further discuss on 40 years of successful interventional cardiology. Thank you.